Welcome to Lecture 7. I'm Dr. Angi Gary. Today we will cover Understanding Cost Effectiveness Analysis. This is a follow-up from last lecture, a practical tool for comparing value in healthcare interventions. Let's recap. What is cost effectiveness analysis? It compares the cost and health outcomes of two or more interventions. Okay, that's quite straightforward. It measures outcomes in a certain natural health units that is comparable. For example, life years saved. Why we do this is because for cardiovascular intervention, you may reduce stroke, you may reduce heart attacks. But when we talk about oncology, our focus is on reducing mortality, maybe returning to work, and preventing disease from coming back or remission. It helps identify which option provides more value for money. In a limited resource environment, every bit counts. So we do need to prioritize what we want to spend our money on. The key metrics we have is this thing called incremental cost effectiveness ratio, or ICER for short. Simply put, cost of A minus cost of B divided by effect of A minus effect of B. It shows what cost you need to incur per extra unit of outcome gain. So the lower the ICER, that's assuming better value, that's assuming that the effectiveness is similar. So for example, if the cost is higher, but outcome is worse, so it's a no-brainer, don't do it. Similarly, if the cost is lower and the outcome is better, please, by all means, go for it. The only trouble is when the cost is higher and the outcome is better. How then do you compare? What is the minimum that you need? For many countries, this is defined to be GDP per capita. So if the outcomes is better than GDP per capita, which we roughly estimate what 1 year of healthy life would entail, then you will do the intervention. For example, for hypertension treatment, if you have drug A, which extends life by 2 years, and you have drug B that extends life by 3 years, and the cost is $100 more. So the ICER is, in this case, $100 per life years gain. This is straightforward. For most countries, they will allow it. But what if it costs you $1 million to extend the life by 1 year? Should you do it? Should you not do it? Is it an individual decision or is it a societal decision so that we do not subsidize, but then we allow the individual look for help either by their own resources or through philanthropy or through crowdsourcing? CA is used by policymakers, health technology assessment bodies, and hospitals. So some of the HTA bodies that I know of is in UK, that's nice. Okay, maybe not so nice. And in Singapore, you have ACE, Agency for Care Effectiveness. It informs which program or which drugs to fund based on a set threshold. This may or may not be revealed to the to everyone, so that the drugs, the medical device companies may not game it. The other factors involved, we need to look at equity. Is it fair? That's very important. As mentioned, a lot of times it's about effective efficiency versus equity. We'll talk about budget impact. Yes, it's good, but can we afford it? Because it may be good, but if you wide scale spread it, the country may not be able to afford it. And there's also ethics matters too, because is it unethical not to fund it, or could we have some sort of in between? Let's fund half, let's fund this, or should we have a value-based funding approach, which means that if it is a good outcome, we'll pay. If it's not a good outcome, the drug company, the medical device will either not charge partially, or charge just the cost of manufacturing, so that it's fairer for the patient since they don't benefit. How cost-effective analysis is done in real life? Firstly, is define the intervention as well as the comparator. For example, screen versus don't screen. This to include both the clinical pathway as well as the outcomes. We use a modeling such as decision tree, or sometimes use a Markov modeling, which if in future if I have a chance I'll cover it. Just to share to know that it just have some key things. There's no memory involved in Markov modeling to stimulate patient journey. We need to assign probability, true positive, who is really positive for those tested positive, and false negative for those tested negative, how many are really negative or free from disease. We need to look at measure the effectiveness. using quality adjusted life years, or can use life years gain. This is usually obtained from published literature of clinical trial. Sometimes we don't have Singapore values, so we can use values from overseas. If we can, we try to also do some of the trials ourselves. We also include the cost of ourselves, because the cost in US, in Australia is very different from cost in Singapore. So we look at direct medical costs, the cost that's incurred directly in the cost treatment. We don't usually look at indirect medical costs, because this is something that is quite difficult to calculate. Productivity gain, time taken for the caregiver to take time off, to take the patient to see the doctor. Because as mentioned, it can be widely variable, and it depends on the assumption used. We use real world data, we use claims data, hospital charges, database from Ministry of Health. Why we do this is because we want this to be as real as possible to inform decision maker. Calculate ICER, as mentioned, cost intervention minus cost comparator divided by the effect gain or lost. So we look at the winners to pay threshold, typically defined to a GDP per capita. Singapore is a strange country. Why I say strange? We are quite rich. Our GDP per capita is quite high. So if we use 3 times the GDP per capita, it may be too high. So this is something to consider. We need to perform a sensitivity analysis, because not all analysis is certain. We need to look at how sensitive is the variable to the outcomes to make sure that it is robust. We can use things like tornado diagram, cost effectiveness plane. I don't have a PhD, so all these things is probably beyond me. Tornado diagram, that's just a working knowledge of it. I think as a beginner, we just don't focus on the details, but focus on what you want to do. So I always clarify things as number one, why? Why do this? Be very clear on why. Next, what to do. This is something you need to be clear. How to do it? You can outsource it to PhD, you can outsource it to companies. Don't have to do it yourself, but you know have some working knowledge on the study disease. So depending on what you aspire to be, do you want to be a decision maker? Do you want to be a researcher? Do you want to be an analyst? The focus should be very different depending on this. So this is for beginner course for clinician. So not all clinicians wants to do the cost effectiveness analysis, but clinician may or should partner with analysts. You can partner with us, health service outcome research, if you're interested to do any cost effectiveness analysis in Singapore. Okay, see, there are some published paper. Look at, I'm not the first author, so we have clinicians, we have Prof. Yo from nephrology department in Toxic Hospital. We did a systematic review on the cost effectiveness of screening for CKD in the general adult population. Should we not? Is there a special population to screen for? I also did a paper with my colleague, Dr. Meng, he's a mathematician, on the cost effectiveness analysis of CPAP for treatment of OSA, obstructive sleep apnea. Personally, I have that. We also did one on to use AI to enhance screening for diabetic foot ulcer. For those who know, we actually do foot ulcer screening once a year for low risk patients, moderate risk 6 monthly, high risk 3 to 4 monthly. Is there a better way to screen? Can we screen the low risk patient every 2 years or 3 years? In Scotland, they're actually doing it for low risk patients. They actually screen for every 2 years. But it doesn't mean we ignore patients. If the patient has an ulcer, patient have any issues, they do still see a doctor. But I'm talking about for patients with no physical symptoms or signs, can we afford to screen every 2 years instead? This is not because screening 1 year is perfect. It's just because we don't have enough resources. We don't have podiatrists, nurses to do that. So this is something to consider. Okay, thank you for listening. I hope this has been useful. Feel free to email me at gary_ang@nhg.com.sg or leave a message on YouTube, Udemy. Thank you so much for listening.